Dear ladies and gentlemen, Kai Gert and myself would like to present you today a new case of the month in the ASAS Case Library. Here we're dealing with a case of a 52-year-old female patient who came to us because of the presence of musculoskeletal symptoms on the background of inflammatory bowel disease. As you see, inflammatory bowel disease, Crohn's disease, is known already for more than 20 years and has been treated with various drugs, including most recently a TNF-alpha local monoclonal antibody against TNF-alpha. She had a history of peripheral arthritis, which has been also well treated with TNF-alpha inhibitor. But what is still there is back pain that started also some time ago, but is still persisting and was not really improving with anti-TNF treatment and also not with other drugs. There are some inflammatory back pain characteristics, including some improvement with exercise, but pain also improves with rest. There is morning stiffness of about 30 minutes, no alternating buttock pain, so it is really hard to judge, to classify here it's as inflammatory or mechanical. NSAIDs could not be taken in a full anti-inflammatory dose because of the presence of inflammatory bowel disease, and there were no other spondyloarthritis manifestations. On clinical examination, there were no remarkable findings. A bit of tenderness over sacroiliac joints, a bit of limitation in the spinal mobility, but no current arthritis, no enthesitis, no dactylitis, no psoriasis, and no uveitis. In the lab, we noticed absence of B27 positivity and currently normal acute phase reactants. So in this situation, it was important to judge whether or not there is inflammatory involvement of the axial skeleton in order to make a therapeutic decision whether or not to escalate or to change the therapy in the case of axial inflammatory disease, or to treat this condition as non-specific mechanical problem in the case of non-inflammatory origin of this back pain. And this is exactly the place where imaging could help us to make this decision. And now I pass over to Kai.
Exactly, and this patient underwent a standard protocol that is showing us the sacroiliac joint and the lumbar spine. You see there are 3 sequences covering the sacroiliac joints, and then 3 another sequences depicting the lumbar spine, and we will go through these sequences one by one. And it starts with this sequence, which is a T1 weighted scan. You see that we have the fatty subcutaneous component as a bright appearance, and we have the nucleus pulposus as a dark appearance. Usually you search for some sorts of fluid, and at the sacroiliac joints, as you don't see the cerebrospinal fluid on a regular basis, it's a good idea to check on the nucleus pulposus, although we need to also check if there are degenerative changes, because then there's no fluid in the disc. We will find out about this later. So this is the T1 weighted sequence. Then we here have a stir sequence. You can see a dark or hypointense appearance of the fatty signal, also hypointense appearance of the bone marrow, and you see these nerve roots here, and also the cerebrospinal fluid in the sacral canal, which show us a bright appearance of the fluid, and also there's some fluid in the nucleus pulposus over here. So that's the check that you always should do when you evaluate MRI of the sacroiliac joint, that you look at the right sequences. The third sequence that we can see here is a wipe sequence. It's a Dixon type of wipe sequence, which is able to show the cartilage and also the joint space in more detail, which we will analyze at the end of this demonstration. So starting with the T1 weighted sequence, you see the joint space looks rather normal. There are no big erosions, which you would be able to see on this T1 weighted image. And also there is the regular signal of the bone marrow next to the joint cleft in the sacral bone and also in the iliac bone on both sides. So there is no sclerosis, for instance, which would then show up as a dark area. There is some, maybe a little bit of signal decrease here on the lower aspect of the left sacroiliac joint, and also maybe, if you will, a little bit of, but only a little bit of low signal intensity here in the very anterior aspect of the joint. But I can only demonstrate this because I looked at the stir sequences some minutes ago. And here you see, if you look at the stir sequence, and if you start at the anterior edge, which is exactly this slice number 19, we see this joint cleft over here, and maybe here we have some doubtful high signal. But if we go to slice number 18, which is a bit more into the joint, we see this bright area over here, which we maybe a little bit also see here, but in the slice number 17, we see more of it compared to the other side. So we would assume there is some very mild bone marrow edema in the anterior superior aspect of the sacroiliac joint. And as you advance through the slices, there's also some very linear and very minor bone marrow edema subchondrally at the right sacroiliac joint in the iliac bone, and it is somewhat focusing on the posterior capsular insertion. So we have the anterior capsule of the joint, which is about here, but there's no edema or soft tissue change. And then we have the posterior capsule of the joint, which you can expect here. And there's some bone marrow edema here, and it corresponds a bit to a maybe capsular mechanical stress. So that's all that we can see. So despite this inflammatory type of back pain, here is rather only very minor bone marrow edema visible, and it's in locations where we would expect mechanical alterations. And these are the super anterior area of the joint and also the area close to the capsules. On the wipe Dixon sequence, we can check if there are any erosions. So here we need to get acquainted a bit with these sequences. So you see the cartilage in the joint as a bright appearance here, and there is a regular contour of the bony surfaces. So there is no erosive destruction over here. So all in all, we have no structural lesions, and we have a little bit of bone marrow edema. So next is the spine, and to demonstrate this, I give the word to Denis.
Thank you very much, Kai. Let's have a look at spinal sequences. Here you see that we have three sequences done for the spinal imaging, spinal MRI. If you look at these two, they look very similar, but you can recognize that the water signal is different on these two sequences. So this sequence is T1 weighted sequence with dark water and bright fat signal, and this one is a T2 without fat suppression. So currently, as of today, we would need for judgment on active inflammatory and structural changes also fat suppressed T2 weighted sequence and done in sagittal view, sagittal plane, and this could be T2 with fat suppression, or so-called stir or term sequence. So we have these three. Let's have a look first at stir or turn. What we see here, first, it is always important when we judge on spinal MRI is to look at the condition of intervertebral discs. And this, for example, and these discs, they look quite okay. They are water-rich. And then you see, in contrast to those water-rich, bright intervertebral discs, several discs which are affected by degeneration. They are dehydrated, they give you dark signals. So here you can expect a sort of mechanical stress to the bone of the adjacent vertebral bodies. And indeed, in the typical localization here, L5S1, I guess, we see also some bone marrow edema, which is rather of mechanical degenerative origin and not related to spondyloarthritis. Also, in several other aspects, you see minor bone marrow edema localized in the corners or end plates of the vertebral bodies, but these are minor changes and they are not very compatible with active inflammatory changes. Also to judge on whether or not this inflammation is related to spondyloarthritis, the story is very similar to sacroiliac joints. We also look at structural changes in on T1 weighted sequence, and what we can see here in the area where we already suspected degeneration, that there are degenerative changes. You see here osteophytes growing, and there are minor fatty metaplasia in the corners, most likely also related to degenerative changes in this area. And here we do not see typical active inflammatory or structural changes compatible with spondylitis or spondyloarthritis. We have also here two other projections or planes for the spine and for the sacroiliac joints. They are providing the same information we have discussed already. So here in this case, all in all, imaging was very helpful to judge on whether or not there is active inflammatory process in the spine or sacroiliac joints responsible for persisting back pain despite anti-TNF treatment. And we came into conclusion that in this case, we're dealing with non-specific back pain, probably related to some mechanical issues in the sacroiliac joints, potentially also in the spine, but we could not observe definite changes associated with spondyloarthritis. And this had clear practical relevance, clinical relevance, because in this case, because of good control of gut symptoms, because of good control of peripheral arthritis, we would stay with currently applied treatment with TNF-alpha blockade and would not necessarily modify the anti-inflammatory treatment. It could be expanded to non-steroidal anti-inflammatory drugs, which are quite safe in patients who are in remission of inflammatory bowel disease. But certainly there is no need to cycle or to escalate biological or targeted synthetic DMARDs. What is your view on this, Kai? Do you see it commonly that patients with clinical phenotype associated with spondyloarthritis are coming to you with a question whether or not back pain is associated with spondyloarthritis?
Indeed, in about maybe 2/3 or even 75% of cases, we in fact have resulting degenerative changes at the sacroiliac joint and lumbar spine when patients come to us for diagnosis of axial spondyloarthritis, and we do imaging, especially MRI. So this is a frequent scenario that we rule out the disease, in fact. And here we have a patient with good risk factors for the disease. There's chronic inflammatory bowel disease. And I'm sure there are some experts out there who say that in Crohn's disease, the changes are not so intense at the joints, and they would rather associate our changes that we found here with the disease. But given our experience with our osteitis condensans patients, I think it is still too few change here, too few inflammation in order to justify an axial spondyloarthritis on the basis of inflammatory bowel disease. Dennis, do you agree?
Yeah, absolutely. And here in this case, we have a history of many years of back pain. Back pain started 10 years ago. So in axial spondyloarthritis, in a disease affecting sacroiliac joints, we would expect to see some structural changes after 10 years. But in this case, we see some mild bone marrow edema localized mainly in the anterior portion of the joint affected by mechanical stress. And there are no typical structural changes, which are quite important if you can see the long-lasting history of back pain. So in this case, the decision would be rather in non-inflammatory direction.
Wonderful. Maybe finally, if you activate the stir sequence, so the stir sequence of the sacroiliac joints, so our visitors can see, if they are not sure, the different interpretation of the bone marrow edema that we did draw in here. So that is usually not the case in a clinical MRI, but here for these teaching purposes, we provide these color annotations.
Thank you very much for listening and watching. Stay tuned. We will be providing a new case very soon.
See you next time.